Good morning, ladies and gentlemen. I'm just testing my mic, but I can tell that it works. My name is Dr. Jackie Stone. I am the Medical Director of Intellectus Campus, which is the teaching arm of Avocare. Unfortunately, Michael Maynard couldn't make it today. He's had to return and he's flown out, so I will be moderating the session. We're very privileged to have speakers from Zambia, from South Africa, and from Kenya, and we have a pharmacist, an economist, and a statistician, which are not in my field because I'm just a plain medical doctor. But I'm looking forward to these sessions. I am going to let each speaker give a brief bio of themselves and then go into their speech. So we're going to start off with Mr. Mubiana Muhau. My pronunciation, I hope, is correct. And he is going to speak first. And I'm really looking forward to his talk because I think all of us during the last 3 years started to use digital technology to consult with patients. And the power of what he is presenting, I think, takes it to a new level. So please, can you put your hands together for Mr. Muhau.
Thank you very much for that introduction. And as earlier indicated, my name is Mubiana. I work for the Center for Infectious Disease Research in Zambia. I work as a pharmacist and also as a public health expert with CIDAS, and we support the Ministry of Health in the implementation of the HIV programs. So I'll proceed with what I've prepared this morning to share the works that we have done around the digital intervention. It's a demand creation tool that aims at raising awareness of the HIV risks amongst the men in Zambia and even during the COVID epidemic. What motivated us to come up with these interventions? Sorry, I think the slide needs to be changed. Thank you. Yeah, so that's my presentation, and I'll go right into it. So what motivated us to come up with this intervention is the results that we saw from the Zambia report of 2021, which showed that 86.6% of men who live with HIV disease actually knew their HIV status. For those that were on ART, 70% of those who are aged 15 to 34 years were actually virally suppressed. So you see that there are still a bit more efforts that are still required to try and push these numbers to the 95. COVID pandemic slowed down our acceleration towards the UNAIDS goals. Because in the country, in the years between 2020 and March 2022, the outreach activities were halted, and this slowed down even further the case finding activities in the community. To this effect, we came up with a way in which we can reach out to the men, knowing that the men are a hard-to-reach population. So that's how we came with this intervention to try and empower the men with some information just to encourage them to come to the clinic. What is this tool all about? So the tool is a self-assessment tool where the men self-assess themselves for the HIV risks and sexual reproductive health risks. It uses artificial intelligence, and it runs on a WhatsApp-based platform. It can be accessed using a QR code or a link that can be shared in various platforms. The tool has 6 modules, which are HIV and sexual health reproduction for the men. These were selected because these are the conditions that men will always ask about, and they do not have the platform normally to ask when they are in the facilities. So we used this as a way of, as part of the entry point. What are some of the challenges, the processes we took in developing the tool? So we had 5 major steps that we took. The first one was the scoping, where we tried to understand and appreciate what the various implementing partner in the countries were doing regarding the digital intervention. And from there, we managed to identify and select one platform, which we adapted to suit our target population, who are the men. So after selection of these two, we created some messages and some flow charts tailored towards reaching out to the men. As the requirement, these messages and flow charts were subjected for validation by the Social Behavioral Change and Communication Technical Working Group. I must mention that between the development and the Technical Working Group, there were a number of interaction where feedback was given just to ensure that the messages are acceptable in the public. Once all this was achieved, then we asked our team of developers to input this in the WhatsApp-based platform. After the inputting, we subjected this now to the user acceptance test. We used the civil societies that we work with within the Differentiated Service Delivery Technical Working Group, just to validate, to ensure that the messages are correct and they are acceptable to the public. After the development processes, what I'm sharing there is an example of a flowchart. Apologies that there's quite a lot which is on the slide, but what I want to highlight there is following the access on your top left, the endpoint for every module that a man interacts with, which is in the bottom right, is the referral to the nearest men's clinic. At the end there is even a number for the men's clinic that is provided with an option for a man to call to seek more information or even to get direction on how they can reach the clinic. Now I would love to share some of the lessons that we learned during the initial implementation. Our initial implementation ran from March 2023 to July 2023. And through the platform, we managed to reach over 500,000 people with the tool, out of which over 54% were the men who are our target population. And out of which the 68% actually completed the interactions with the tool, so they managed to get the messages. On your right, it just shows the distribution of the populations that we reached. It shows that the majority population that we reached were based in Lusaka province, and followed by the Copper Belt provinces. These are the highly populated provinces in the country, and probably even the population there are ever looking on the social media to see what is trending. The other lessons that we learned from what you can see on the screen is that majority age group that was reached was 25 to 34, followed by 18 to 24. This is very exciting because this is the group that has most of the gaps, even when it comes to case finding, for those who know their status, as you saw from my earlier slide. So this gives hope, and that when we expand the accessibility, we will reach to many more people that require the help. this should be my last slide, where I'm going to discuss the next steps. So following the initial implementation, there have been some ongoing conversation with the Ministry of Health to see if the Ministry of Health can take the ownership of the tool, and also to increase coverage. We wanted to tap into the Ministry of Health SMS platform, where this link for the tool can be broadcasted to everyone who has a phone in the country. By so doing, they will click this link and take them to the WhatsApp platform. From our interactions, there have been also some feedback or recommendation that we can use the same tool to adapt and try to reach different other population other than just the men. Maybe we can also input to reach out to the women for cervical cancer screening and many other demand creation activities. That is the QR code that you can use. When you scan that one, it will take you to the WhatsApp platform, which you can interact with, and you can choose any module that you want to interact with, and you'll be referred to the nearby, to the nearest clinic. Of course, not here in Zimbabwe, but in Zambia. Lastly, I would love to thank the Ministry of Health for allowing us to work and for collaborating with them, Global Fund and WHO for the support during our implementation, and indeed all other implementing partners that we collaborated with, together with the team that is here within the building. I want to thank you all. Thank you.
Thank you very much. That was an extremely interesting presentation, and I think in Zimbabwe we will certainly be contacting you. I'm looking at someone in the audience at the moment who would be very interested in this platform. Our next speaker is Sipiwe Ngwale. She is an economist from South Africa, and I'd like you to give her a round of applause, and she will introduce herself and give a presentation. We will save all questions and answers for the end, and I will put questions to all three speakers. So, Sipiwe, please go ahead with your presentation.
Thank you. Good morning to you, Chair, and everyone else in the building. My name is Sipiwe Ngwale. By profession, I am an economist with a background in business consultancy. I am working with Clinton Health Access Initiative, CHI for short, with the Access to Medicine program, specializing in advanced HIV disease. And this morning, I would just be talking on the interventions that the South African National Department of Health, in collaboration with CHI, did for improving TB lamb uptake in South Africa. Just to give you a bit of a background of the TB burden and the HIV burden in South Africa, South Africa is currently one of the leading countries with the highest TB burden in the world. We rank around 8th amongst the top 80. And we account for about 3% of all TB and PTB cases around the world. Additionally, South Africa is one of 14 countries that face what we call the triple burden, which includes DSTB, DRTB, and HIV-TB co-infection. So following the guidance from the World Health Organization on the use of Aleflam for tuberculosis case finding among patients with advanced HIV disease, South Africa then in 2017 introduced the Determine FL-LAM antigen, which is what we coined TB-LAM in South Africa. So this test is used for patients with advanced HIV disease to detect TB. So patients with a CD count less than 200. Following the decision and the guidance of the WHO, a pilot was then spearheaded by the South African National Department of Health, and this pilot was then conducted in 5 hospitals in the country. So the reason for doing this pilot was because we wanted to be able to assess the feasibility and the use and the adoption of this test within the South African context. Through this pilot, we had approximately 3,000 tests that were distributed to hospitals in pack sizes that came in 100 strips per pack kit. However, many of the sites were not able to absorb these volumes because there's an issue in South Africa where we have limited capacity to store large quantities of tests and medicine packs. The challenge of the absorption of the 100 strip test size kits led to high volumes of wastage. Due to this, it was then realized that the 100 strips pack size that came for the TB lamb test would become an issue in the South African landscape. Due to this, the South African National Department of Health, along with CHI, worked very closely together with provinces to collate feedback and then share it with the supplier, which then led to negotiations so that we could reduce the pack size kit that would fit into the South African hospital landscape. So then the test size kit was reduced from 100 tests per kit down to 25 tests. So when this new pack size kit was then introduced, being the 25 strips per kit, it came with a significant price increase of around 96%. So if you can see on the chart there, when we started with the pilot, the 100 strips per pack were at 48 South African rands. And then as soon as we then negotiate with the supplier and then introduce the 25 strips per pack, it increased to 94 rand. Whereas the global price was sitting at 68 rand. So globally, yes, the price had increased, but only by approximately 5%. But in the South African context, the supply had increased by 96%. And this huge increase in price then slowed down the uptake of the product because it became unaffordable for many provinces and facilities to be able to buy this product. So the interventions that took place to be able to address the challenge of the slow uptake of the product that was due to the sharp increase in price was that the South African Department of Health, along with CHI, had drafted a price memo, which was drafted to challenge the price increase that was given to South Africa in comparison with the global price. This price memo was aimed at engaging with the supplier, and furthermore, the National Department of Health asked CHI to support with technical assistance in engaging further with the local supplier to specifically address the costs of these packs. The technical assistance that was given to the National Department of Health offered a huge success, and the success led to a 25% decrease from 94 Rand to 64 Rand, which is now at par with the global price. Following these negotiations with the supplier, trainings across provinces then took place, and the guidelines were then updated to accommodate the use of the TB lamb. These trainings then capacitated many cadres of staff to administer TB lamb in both inpatient and outpatient settings in our country. Apologies for that. So following the reduction of the price, South Africa saw an exorbitant amount of increase in uptake, whereby the increase of this product was fast-tracked and decentralized the test that was originally only made available in hospitals, but now decentralized to other facilities like your primary healthcare facilities and other private facilities such as mines, correctional facilities, so on and so forth. Just to highlight a few provinces in South Africa, so you can see how much the price reduction actually led to an increase. Provinces such as Limpopo had then vastly increased from only being made available in about 2 hospitals, and they had increased to now being made available in all hospitals, which are 36 hospitals, and about 473 clinics. The other that you see there include correctional facilities, about 3 of them, and they also include mining houses. So it's also worth to highlight that the number of eligible HIV positive patients that tested for TB using TB lamb had increased significantly by almost 3,000%. In 2021, we had only 1,768 patients that were tested using TB lamb. But in 2022, after the price decrease, 54,239 patients were then tested using this TB lamb. The TB lamb is also now included in what we call the regular supply chain planning and quantification that is now backed up with sustainable funding by provisional conditional grants. So what are the next steps for South Africa when it comes to TB LAM? The suggested next steps for the country is that we need to consider expanding more point-of-care diagnostics such as TB LAM to enable immediate screening and linkage to care for HD patients. To do this, health systems need to be strengthened and sensitized to point-of-care tests. Monitoring and evaluation also becomes a continued challenge in South Africa, as it is still captured manually through what we call a TB identification register. And the data capturers often do not either, capture the data correctly, or they do not upload the data on our digital platform called tier.net, which makes reporting and just, monitoring the uptake quite difficult. Additionally, another challenge which needs to be addressed is the infrastructure capacity challenge in South Africa. It needs to be improved because many healthcare facilities report not having enough rooms to be able to conduct the multiple point-of-care tests at the same time whilst attending to patients. And such tests need to be run in individual consultation rooms by a clinician. Most facilities also still have a limited number of consultation rooms and cadres of staff, which becomes a limiting factor to the number of tests that are being able to be performed within a day in South Africa. With this being said, I would just like to thank the South African National Department of Health for spearheading this whole pilot and by helping to increase the point-of-care testing for TB in South Africa amongst advanced HIV disease patients. And I'd also like to thank Unit Aid, who is our grant sponsor for this. Thank you very much.
Thanks very much, Sipiwe. That was a very good presentation, and I personally have some questions for you after this. The next speaker I'd like to introduce is Mr. Stanley Nyoro. He is here as a statistician, and he has come in from Kenya. So as well as that, I'd like to ask the technical team, I'm about to run out of power on my laptop on the screen here. Can we please get some charge onto this device? Thanks very much. And Stanley, the floor is yours.
Thank you very much. So my name is Stanley Nyoro. I work as a research lead with a company called TICO. We previously were called Triggerize, but we have soon rebranded and we are called TICO. So I will take you through our presentation on how our digital platform has empowered the adolescents and young people to access HIV and mental health services in Mombasa, Kenya. So let me introduce you to TICO. So TICO, we work with adolescents. We work with AYPs. Sorry. There we go. So we work with AYPs that are aged between 15 to 24 years to offer access to SRH, HIV, and mental health services in about 5 sub-Saharan African countries, which include Kenya, Ethiopia, Uganda, South Africa, and Burkina Faso, and soon we'll be venturing into Zambia market. So we have a digital platform that motivates AYPs to access these services from our TICO healthcare providers in this market. And the way we motivate our users is that we combine information and behavioral nudges, and these include offering SMS reminders, for instance, to notice them the time that they are required to come back for a service. We also offer subsidized services whereby all the TICO users are able to access free services from all our TICO facilities. Also, we have a reward system called TICO Miles, whereby whenever a user rates our service, then they get a TICO Mile, which is equivalent to $0.5, which they can redeem to retail outlets in case they have a need. So the rating that they provide enable us to get their feedback, and that also assess the quality of service. And whenever there's an interaction from a user with our service, then there's a trigger message. This trigger message connects to our platform such that we are able to tell where this user is accessing this service from, what is the demographic profile of this user. And now from that, we can be able to get the real-time data that we can be able to put in our dashboard, and also to measure the impact of any intervention that we have. So let me introduce you to the background of our program that is being funded by IJAF on mental health. It has integrated mental health and HIV treatment in Mombasa. So the program started in May of 2022 and will conclude in September of 2024. It targets AYPs who are 15 to 24 years, and this includes the members of the key population. So the goal of the program is to enhance and improve mental health and HIV health in this county. Our hypothesis is that AYP who are taking ART and PrEP will have better adherence if they are tested or if they are screened for mental health and they are able to get mental health treatment among those who have been diagnosed with depression. So that is a background of our program that is being implemented in Mombasa. So this is our user journey. So our user journey, we start with enrollment, and enrollment of AYPs is either done by mobilizers at the community, or it is done through self-enrollment. And this can be through phone for AYPs who have a phone, or it can be through a digital card. So if you do not have a phone, you are given a digital card so that it enhances your enrollment. And I would also like to point out that we have two pathways for mental health. So it can either be done from the community through a model called IPTG, which is interpersonal group therapy, where users are able to be screened for mental health. And for those who are suffering from depression, they are taken through an 8 session from the community so that we have an improvement in their mental health outcomes. Apart from the mental health, apart from the pathway that is done from the community, we also have a pathway that is going through the facility where users are able to be screened for mental health, and those that are suffering from depression are also taken through a counseling session. So whenever they take a mental health, also they can take a HIV test, and those that turn out to be positive, we start to track their adherence to treatment because they are already going through a mental health service. And for those who have turned out negative, we are also able to track them from the platform in terms of their adherence to PrEP, especially if they are members of key population or they are at risk of getting HIV. So you may wonder why in Mombasa. So Mombasa is in Kenya. It is the largest city with a population of about 1.38 million. Also, it has a higher HIV prevalence of 4.8%, which is above average. So you have a national average of 3.7%. So the HIV prevalence in Mombasa is relatively high. We also have a relatively large number of key population. We also know that mental health is a global phenomenon whereby 1 in every 4 people are estimated to be suffering from a mental health disorder. And we also know from research that young people who are living with HIV are more likely to be diagnosed with a mental health disorder. Therefore, there is a need to treat mental health disorder as a HIV care, adherence, and prevention strategy. So we have conducted a number of research, and one of the research that we have conducted was a baseline survey that was done through a quasi-experimental design in Mombasa and Kwale, where we interviewed AYPs. And what came out from that research is that young people have challenges in accessing HIV and mental health services, and this is due to several factors, especially there's low awareness of PrEP, and not many users know about PrEP. There's also low awareness about existence of mental health support services. Also, very few AYPs were aware that utilizing ART will lead to undetectable viral load. So apart from awareness, the research also found that AYPs are depressed. And we were measuring depression through PHQ-9, and we identified that about 35% of AYPs who are aged between 15 to 24 years were depressed. And those that were depressed also are suffering from low self-esteem. This was measured using the Rosenberg scale. And linked with low levels of awareness, there's low utilization of PrEP, especially by the key population, are those that are at risk of getting HIV. And also there's low utilization of mental health services at a facility. So further from the research, we did a segmentation study to identify what are the factors that are attributed to suffering from mental health depression. And the research found that financial stressors were causing 68% of all depression cases, and were affecting the youth who are 20 to 24 years, those who are in college, and those, they have higher level of education, so they are suffering from financial depression. Then we identify another segment called the social or emotional depression. And this was affecting users that were aged between 15 to 19 years. And these were especially males. And there's another category of depression which we call distress. Distress is for those users who are either suffering from financial depression or from social depression. And this was linked with causing severe depression. So let us go to the dashboard data. And from the dashboard data, we have the number of unique users who have taken HIV surveys from January of 2023 to November of 2023. And from the dashboard, over 8,000 unique users have taken HIV surveys that have been offered by TICOM. Then we have the number of unique users who have taken an integrated service. So they have taken a mental health service, and in addition to a mental health service, they have taken a HIV service. And from the dashboard, we can see that over 2,000 unique users have taken an integrated service, and this has been an increasing trend. So more users are more likely to take integrated service by the end of the program, which will end by September of 2024. So let's go to the impact. And one of the impact, although we measure more impact at the headline because the program is still learning, but there are initial impact that we are starting to see. First of all, our model is encouraging repeat use of HIV surveys in Mombasa. For instance, we operate in over 10 counties in Kenya, and in counties that have not integrated mental health service, the average repeat use is about 13%, but in Mombasa, the number of repeat service users was 37%. And therefore, we can link this to the positive outcome of integrating mental health treatment with HIV services. So, So another impact is our community model. Our community model, as I mentioned, is the IPTG, the Interpersonal Therapy Group. And this is offered at the community level. And it is offered to AYPs that are suffering from some form of depression. So they are taken through an 8 session, which lasts about 8 weeks. And at the beginning, before the start of the session, they are screened for mental health, whereby everyone is suffering from mental health depression. Then at the end of the session, they are still screened. And what we see is that at the end of the session, there has been a decline by over 73% among those who are suffering from depression. And therefore, we can attribute this to our community model in terms of lowering depression. So what is the way forward and what are the key takeaways? Is that our model is encouraging repeat use, which is an outcome. We are also reducing depression status among AYPs. And also through our platform, we can be able to monitor and make adjustment, which is called adaptive programming, to further inform and make adjustments whenever necessary. And lastly is that utilization of behavioral nudges promote positive behavior change. Thank you.
Thanks very much, Danny, for that. It was a very impressive presentation. Sorry, I'm losing my voice. One of the things that we've been presenting on some of our Intellectus Campus sessions is mental health and substance abuse disorder and HIV. And we know that at least 30% of people living with HIV suffer from depression. And we need an integrative approach to this, which includes nutrition and financial support. And I'm very impressed with what your interventions were like. On the chat on the group, we've had a request that the presentations can be shared for virtual participants, if that is possible, because they're having a few network challenges. So before I go ahead with any questions, I'd like to ask anybody in the floor whether they have any questions for our three panelists. And we have three hands there. So let's start on the right. Gentleman in the black shirt. Do we have a microphone? The microphone's behind you.
All right, good morning. So my questions go to, I want to appreciate all the presenters for their presentations. My question goes to the last presenter. Very interesting concept and implementation. So I want to find out a few things. One, the TICO program. Is TICO a downloadable app? Is it like an app that is downloadable and phone users could download and interact on it? Or how does it work? And secondly, you mentioned digital card for those who don't have phones. So how does it work? And how regular are we able to interact with people who have digital card without possessing mobile phones on the digital platform? Then again, you mentioned intensifying feedbacks, that there is incentive of $0.5 to everyone that provides feedback. And there's something about incentives in programming. Sometimes it steers people to want to just respond, whether relevant or not. So have you analyzed your feedbacks to see how many relevant feedback do you have? Do people just provide feedback because they want the incentives? Do they provide productive feedbacks that help programming? And lastly, I'm interested in hearing about the digital mental health intervention. And you talked about the impact, how mental health, how depression among program participants decreased by 73% between their time of entry to the program and when they are through. So I want to know what is the content of the digital mental health that you implement. Thank you.
Okay, I'm going to take the two other questions, and then Stanley, can you formulate an answer? The gentleman in the blue shirt at the back.
No, I think I'm going to write first, Professor Dembe from the African Union Commission. I'm going to write on the question from the previous delegate here. I think it's very important. First, congratulations to all the presenters. Excellent presentation. I think I have specifically for TICO, I have a very challenging question for you. The tools for neurocognitive impairment, whether it is depression, they are really complex and they need to be calibrated. And that's back to the question of the gentleman that came before me. If the tools are not accurate, you might overestimate, and what you're seeing is a reflection of that bias on the use of the tools that are not adapted to our local context. Having I've been a PI of a neurocognitive survey from the NIH. We have seen such discrepancy. I'm not challenging your study or the outcome, but I'm saying it's good that we look into some of those details. The second, I think, again, that's on PrEP, because there were a lot of things in the integration services that you're providing, which is excellent. It's the acceptability to PrEP, oral PrEP. And you conducted a small survey ensuring that probably with cabotegravir that is coming, long-lasting injectable, that we can definitely roll out in our own particular context. Again, thanks to the chair, excellent moderation. And for all of those who have been able to attend this last session of ICASA, I think you're brave people for this continent. Thank you. Back to you.
Thanks very much for that. And the gentleman in the blue shirt, we're can you ask your question and then we'll proceed to answers?
Okay, thank you very much. I'm Nyaradze, I work for PSH. I've got a question for the first presenter. You talked about use of WhatsApp platform. I wanted to know on your demographic, you said that in Lusaka, I understand Lusaka is the capital city of Zambia, and it's expected that in a capital city we have more people staying there. If you try to assess whether the numbers you see in Lusaka are due to availability of the mobile phones as compared to other places that are more rural, and trying to do comparisons and not necessarily say that the uptake is good in Lusaka compared to other places. I think it's something that you need to look at. And you need to look at if there's an option for SMS as well, because WhatsApp needs data, and or toll-free kind of a platform where people can send messages for free without any charge, which is something that can restrict people that are from poor areas. I don't know if that's something that you are considering in your application. And for the lady who presented from South Africa, the economist, you mentioned that the uptake was due to price reduction. And I wanted to question that, to say, is that really the major cause for the uptake that you saw increased? Because I'm working in a program where we have poor uptake of TB lamb due to logistical challenges. For example, they have to collect their urine. And at times you're doing outreach and you don't have the capacity to collect the urine to take to the laboratory. Is it something that you have tried to look at, other confounding factors, rather than just looking at the cost only, which I think cost is only improving access and not necessarily the uptake of the intervention. Then lastly, I wanted to ask the TICO, is the therapy done online for mental health, or they will go physically after having booked online platform for the therapy? Thank you.
Thank you very much for those excellent questions. We've only got 3 minutes left in the session, but we can run slightly over if people want to stay. So I'd like to ask Mr. Stanley Nyoro to start off with answering questions, and then we'll go to Sipiwe, and then we'll go to Mr. Mubiana. So over to you, Stanley.
Okay, thank you. So let me start with the first question about the interactive app. So it is very interactive. Users, for instance, at the time of enrollment, they can be able to self-enroll from WhatsApp, from Telegram. And we also, that data will come to a platform that you can be able to analyze. So the app is very interactive. It can be downloadable, but also you can be able to access the features of the app using other means like the social media platform like WhatsApp and also Telegram. In terms of the card, so this is our card, and it's for inclusion, because you will not expect that most of the users aged 15 to 24 years will be able to have a mobile phone number. So for those that do not have a mobile phone number, we still enroll them, and they can be able to access a service. So for instance, whenever they go to our TICO providers, they will produce this card. So the mobilizer, the provider will be able to get hold of this card and also do some swapping, do some connections. And from there, we can be able, a trigger is sent with the data about where that user is getting the service from and where the type of service that they have been provided. And after they have gotten a service, then of course they will be able to get their miles. So let me come to the question about our tool. The tool in terms of whether we have let me come to the question about the tool that we use for mental health screening. And I would like to say that we work with trained counselors that have undergone through counseling services, and therefore they are qualified in terms of providing the counseling at the community level and also at the facility level. So the facility level especially is done by the facility provider who have undergone such training. So in terms of PrEP, we have been offering oral PrEP. So injectable PrEP has not been introduced into Kenya yet, but that's something that we can explore when we have that opportunity that it has been introduced in the country. But so far, that has not been introduced in the country. And in terms of whether you have online session, so our sessions are mainly face-to-face. The interpersonal group therapy is mainly face-to-face, and also the facility is mainly face-to-face. But I also like to point out that we have a telecounseling. For instance, if you are suffering from depression, as you know, you might not be able to access or go to attend this group. Then we have a telecounseling service where you call and you are provided with mental health.
Thanks very much. I am aware that the session is about to close. So, Spiwe, could you give us some comments on the uptake of TB LAM?
Okay, thank you. To the gentleman that had asked the question, yes, it actually does have to do with price increase, the price increase and then the decrease. So what we saw was when we started the pilot, as I stated, we did it only in 5 hospitals, and then we started to increase the number of hospitals, and the uptake was doing quite well until the price increase. We saw a decrease. So we have a platform, what we call RSA Pharma, which we are able to monitor number of orders that are taking place in provincial depots. So we had realized that when the increase had taken place, there was a decline in the number of orders that were ordered for the TB LAM. But it's not just the price, it's also training. So at the same time, we had to still upscale a lot of trainings in provinces to take place. And TB LAM actually is in demand because cadres of staff prefer to test with TB LAM. Remember, it's a point of care test. So on the spot, you are able to screen, diagnose for TB. You don't have to send it to a lab. It's actually so much in demand that we're currently having a challenge of clinicians using it for people who don't even have advanced HIV disease because it's just so convenient for them. So we did actually link the uptake, as I've stated. Number one, it is because of the price decrease. We saw that when the price decreased, there was a huge uptake in terms of numbers that were taking place in the depots, and then secondly, increase in training as well. That also led to the uptake. Thank you.
Thank you very much for that. And we're going to close with some final words from Mr. Muhau.
Thank you very much for the 2 questions. The first question was whether or not we tried to consider the use of SMS. The answer is yes. At the inception, when we started developing the messages, in mind, we wanted to go with the SMS because we are looking at how many people can access the SMS versus those who can access internet. So we went with the SMS, we developed the messages. Even the user acceptance test was actually conducted using the SMS. But what we learned when we were about to roll it out was the fact that the service providers, mobile providers, were charging for every message that the recipient of care sends. So that shifted the cost to the user instead of the implementers. So with that realization, we had some engagement to see whether there could be a waiver so that we can these messages can be free of charge. But while we are doing those conversations, we thought of going with the WhatsApp so that the cost would be actually on the implementer instead of the user. So what we have done is there are certain licenses that we have bought for us to be able to manage this platform. The second question was, while Osaka is the showed a lot of people, yes, what I've shared was the results of the initial implementation. The initial implementation was actually conducted in the 5 provinces. What is very interesting is while we only restricted some messages, some adverts to only those 5 provinces, even other provinces which we showed accessed some of the messages. So it was quite very interesting. So as we go to the next step to try and broadcast this to increase the coverage, yes, indeed, other provinces will have access in large numbers. Thank you.
Thank you very much for that. And we're now 3 minutes over time. What I suggest is if anybody has any further questions, the speakers and myself will be up here to answer them. And I think the issues of point of care testing of adolescent mental health and of the use of WhatsApp in consulting, we could probably speak about it and have a conference on it on its own. So thank you everybody in the audience for attending. Thank you to the speakers for your superb presentations. And with that, I'll close the session and invite anybody who wants to ask further questions to come up to the front. Thank you very much.